about, we're going to continue our conversation utilizing the F tags to talk about your role as an infection preventionist. Jessica has dropped a link into the chat of the PDF. If you join or if somebody joins after, we will put that in again, probably in 10 to 15 minutes. So just sit tight and we'll continue. We put that in throughout the presentation periodically. We'll drop that in chat. I am working today from a hotel room, so I am going to go off camera just to conserve the bandwidth to make sure we don't lose signal. This is the joys and benefits of working from home and co-virtually. So I'm going to go ahead and share my screen. All right, and I'm going to turn my camera off so you're not looking at yourselves, and I can. Maybe I'll turn my camera off. All right. So today we're going to talk about hand hygiene. We're going to start with F880 and we're going to talk about some of the basics that everybody understands about F880, but we're going to do a little deeper dive into why those are included in basic infection control. As we talked about last week, F880 is the F tag that kind of houses all of the basics and fundamentals of what we know to be infection control regulations. It really is your instruction book on the things that are required in your infection control program. It's the basics. And so today we're going to kind of get back to basics and we're going to talk a little bit about hand hygiene and its importance in preventing spread of infections. We're going to talk about the different types of transmission-based precautions. We're going to talk about helping you understand your role of surveillance in an infection prevention program and why surveillance is so important. Then we're going to talk a little bit about managing an infectious outbreak. I know that's probably going to be a little redundant for those of you that have been doing this for a few years, but we do have a lot of new infection preventionists. And so we just want to go through that just for a clear understanding and to answer any questions. And then we're going to talk about your role as an infection preventionist or the role of the infection preventionist in a quality assurance and performance improvement in QAPI and talk about what that looks like from an IP's perspective. So there are many aspects of an infection control program. And the first and foremost thing is that it's important that employees recognize their role in promoting a safe environment and the importance of following infection prevention practices. So we're going to start with some fundamentals and we're going to talk about we're going to go back and talk about some of those basics, but really talk about it in a manner that allows you to ask questions and give some good examples of things that we have seen and pulled from 2567s, and then talk about some of the examples and how a surveyor reviews or what it looks like from a regulatory perspective from their view. So let's jump right into hand hygiene, everybody's favorite topic. I know you probably can do this in your sleep. You probably do this in your sleep. If you're somebody that trains on hand hygiene, you probably think about it. But let's just dive in about what F880 tells us around hand hygiene. So it defines hand hygiene, and hand hygiene is that general term that we use for cleaning our hands. And in long-term care, we focus on not just hand washing, but antiseptic hand washing using alcohol-based hand rub. And one of the questions that you need to consider or ponder is, what does your facility policy or procedures say about hand hygiene? And does it mirror or match what the CDC guidance is and that of F880? And on the bottom of this slide, the Clean Hands Count campaign, that is the CDC page. It's a link where you can find a ton of resources on education, training, videos, posters on hand hygiene. So, does your facility hand hygiene policy and procedures state that alcohol-based hand rub is preferred? That is the polling question. And Jessica, if you're able to bring that up. And Jess, I'm not going to be able to see it on my end. Oh, I am able to see it. Well, look at that. Guys, we're testing this new technology. Awesome. So we're seeing that the bulk of everybody is saying yes, and just a few I don't knows. So your policy should state that ABHR is the preferred method for hand hygiene. That changed mid-pandemic. It became the best standard, the best practice. And I know that when you're working with staff, some staff that have been in long-term care for quite some time do prefer soap and water, but we need to educate them on the why behind alcohol-based hand rub being the preferred method. I will share that in some of the, I'm going to share the results so you guys can see those. So in some of the 2567s that we have read or looked at, facilities have gotten cited for improper use of soap and water hand hygiene practices, meaning that staff missed a step, did not perform it for long enough, did not do a good scrub, didn't use, it can be a very picky process to be surveyed on. So the recommendation is the use of alcohol-based hand rub because it is quick, it's thorough, it's an easy to remember and teach staff. And if you have it readily available, it's going to be done. Your staff are going to actually clean their hands. So why is hand hygiene important? We know that it's the first line for preventing spread and transmission of infections for residents, staff, and the community. Infections can be transmitted on the hands and it can be fatal. Elderly, we know, have a reduced ability to fight infections. Bacteria, viruses, and fungus can survive on surfaces for days. So even if a surface looks clean, we put a clean hand on that surface, we may pick up a fungus, a bacteria, or a virus and not realize it. And if we don't wash our hands and then we touch something else, we've now spread that bacteria, virus, and fungus unknowingly. So the quality of your hand cleaning matters. And it is, and it continues to be the most common reason for F880 citation. So we talk about something so simple as hand hygiene. It continues to be the most common reason that facilities get cited for F880 is the failure to perform hand hygiene. And it's the failure to perform hand hygiene with tasks upon observation in situations such as wound and dressing changes, in observations of pericare, observations of passing linen, passing trays, passing medications, and interacting with residents. So when you look at your facility and you think about your hand hygiene program, that's why it's important, right? That's the why. So in your policy and in your procedure, and in F880 and in the surveyor, the SOM, and the guidance, there's instructions on when, and CDC guidance down here on the bottom is the link, but when to perform hand hygiene. When we perform hand hygiene with soap and water, here's the when. When it's visibly soiled with blood or body fluids, before eating, after using the restroom, when patients have diarrhea because they could potentially have C. diff or norovirus, and when ABHR is not available. And we should always follow the facility policy or procedure and do it for 20 seconds or greater. Alcohol-based hand rub is the preferred method for hand hygiene, except as mentioned on the previous slide. And the reason is that ABHR kills organisms more effectively and quickly than soap and water. Your product should be at least 60% ethanol or isopropanol alcohol. And your facility should have dispensers at the entrances, common areas, in every resident room, and in your hallways. Hands should be rubbed with gel for at least 20 seconds, covering all surfaces until dry. We get asked this question a lot, and this is a point of contention. I've been reading it on some of the infection control boards that I follow. Follow the directions of your fire marshal if you are concerned about using alcohol-based hand rub in your hallways outside of every resident door. There are rules about how the spacing of and where you can place ABHR dispensers, but there is no rule to state that you cannot have them outside of every resident door. Some of the better recommendations that I have seen and where I've seen facilities implement this successfully is where they have a foam in, foam out process that they teach staff to perform ABHR cleaning on the entry in and the exit out of every resident room, meaning that there is a dispenser inside the door and outside of the door of every resident room wherever feasible and possible. Now, we do get asked, and I've gotten asked this, and I know my fellow QAs have been asked this also, what about resident consumption? What about residents that may try to consume alcohol? And I would say to you that there's a couple techniques that we have seen to be very effective. One is placing the alcohol-based hand rub that your staff are going to be using at their eye level or higher, so like eye level, and utilizing one of the drip trays on the bottom of that dispenser so that your hand can slide in, but you could not easily put a cup in your mouth, a cup for your hand to contain the alcohol for consumption. Also, most of the dispensers now are utilizing a foam product. The foam product seems to, it doesn't look like a liquid product, and it is a gel. It is not a thin liquid like we may have been utilizing during the pandemic. So if you have questions about that or would like more information about placement of that, please reach out and we can get that, we can get those resources to you. Here is the 5 moments of hand hygiene poster that the World Health Organization utilizes. I think this is a great poster because it just kind of talks about the when and the why. And then these are the requirements right out of the FTAG. These are the requirements for a good hand hygiene program. Staff need to have the knowledge about when and how to perform hand hygiene. That is where we see most citations. They need to know when to do it. Policies and procedures have to include it, and you need to have education and training on hire annually as part of your competencies as needed with changes, like if you change your product, you change placement for staff, residents, contractors, families, and visitors. So your education in FA 80, it talks about educating your residents and your families about hand hygiene. You should have visual reminders. You should need to have the availability of supplies, and you need to have some mechanism for compliance monitoring. And then obviously feedback and performance improvement and changes to the plan if needed. So that plan, do, study, act, part of QAPI. And of course, if you're doing surveillance on hand hygiene, it needs to be reported to your infection prevention committee and QAPI. So let's talk a little bit about staff competency with hand hygiene. And I'm sure everyone on this call, you have all performed hand hygiene competencies with your staff, where you take your staff to the sink and you have them demonstrate, or you take them to the alcohol-based hand rubs, to the dispenser, and you have them demonstrate their process. I'm going to encourage you to do a couple things differently. One, I'm going to encourage you to silently and quietly just do observations of your staff in nature, I guess is how I describe it. Just walk up and down your hall, don't have a clipboard, but just walk up and down your hall and observe staff coming in and out of resident rooms. Observe your nursing staff pulling medications and doing med tests. Observe your staff performing peri-care, wound care, developing, passing trays, passing linen. Are you seeing them utilizing alcohol-based hand rub? Are you seeing them perform hand hygiene in the steps of your process where your policy indicates that it's needed and necessary? And if you don't, what do you do about it? And that's where we start with competency and education. And one of the recommendations is something that I introduced to a building this week and that I've done before, it seems to work, and that's the teach back method. And for this particular teach back for hand hygiene, sometimes it's just the importance of asking staff, going up and interviewing a staff member and using a scenario. Like, hey, Jessica, I want to ask you a few questions about about hand hygiene. You know, this is important. It's part of our infection control process. And I know you've been a CNA for quite a while. So I know you've got a lot of knowledge about hand hygiene. So can I ask you some questions about hand hygiene and when it's performed with a particular task? And Jessica's going to say yes, of course, right? I'm supervisor. So Jessica, here's the scenario. When you go to provide care for Mrs. Smith, let's say you're going to provide her with peri-care. When would you perform hand hygiene during that process? Walk me through your process of how you perform peri-care with Mrs. Smith. What that allows, what a scenario-based situation or an interview type surveillance does, or interview type surveillance does with your staff, is it makes them use critical thinking skills about their knowledge that they're doing by rote and actually verbalizing it to you and how it's applied. And what you're looking for and listening for is to hear and see if the staff member can walk through in their mind the process that they use and what they do and when they perform hand hygiene. So just a different way to think about it. I know hand hygiene auditing, here's a bunch of resources on hand hygiene, education and audit tools. We have them from our, Superior Health has a whole page dedicated to hand hygiene. If that's a program, Frontline Forces is an educational tool that you can assign to staff or have staff enroll to take and learn about why hand hygiene is important. IPC Well and Dr. Buffy. We have Wisconsin Department of Health and Services. We have CDC videos. Again, if you need resources, just reach out. But I would challenge you and your department heads, your interdisciplinary team to get out there and think about what are some new ways that we can reinforce staff learning and education and make sure that they're really grasping the concepts of when hand hygiene and alcohol-based hand rub usage is important in part of their work. Jess, do we have any questions? I see the chat has 3 just before I continue on.
Those are links I've posted, but we don't have any questions.
Awesome, thank you. All right, so now we're going to talk about compliance auditing and the steps in compliance auditing. So when you talk about compliance auditing as far as hand hygiene, I just gave you a scenario-based audit. So when you talk about doing surveillance audits, the first step is to select the applicable audit tool to assess compliance at the individual department or various shift levels. What is the tool that you're going to use and why are you going to use that tool? And you want to make sure that the person who you're assigning the audits to, and oh, by the way, infection preventionist, it's okay. And you should be enlisting other leadership team members, other nurses, and each other in the purpose of being audited, in auditing. But when you do that and you enlist other folks, you want to make sure that the person that you have conducting the audit is competent in the area being assessed and that they can demonstrate competency to you before you go out and have them do audits on that topic with somebody else. You want to observe for specific areas within the process where missed opportunities and improper technique occurred. So in the example of doing an observation on hand hygiene, where I had you just kind of going out in nature of your hallway and observing your staff, are you seeing trends? Are you seeing missed opportunities? Are you seeing the same missed opportunity multiple times when you're doing that basic observation? If you notice a trend or you notice a pattern, that would be your opportunity to consider that's what you're looking for and that's what you're going to audit. So the first step is educating staff on the auditing process and provide feedback in real time. So tell your staff, hey staff, and pull everybody together in a huddle on the hall and say, hey, and don't point fingers. This is not about people, it is about process. Remember, when we do anything quality improvement, we're looking at a process and the success or less than success of that process. So educate your staff on what you just observed. Say, hey, I noticed, I did some observations today on Sunshine Lane, and on Sunshine Lane, I noticed that, sometimes we missed hand hygiene being performed when we were coming out of resident rooms. I didn't see people necessarily using their ABHR, or I saw you bring, a tray into Mrs. Smith, and I didn't notice that you did hand hygiene when you came out of the room after delivering her tray or feeding Mrs. Smith. Whatever it was that you observed, and talk about it in real time and say, these are the opportunities to, that we need to learn from, and explain the why. Staff need to understand that it's not just, you didn't do something wrong. It's why we need to do something better. And it's all about how you approach it with your staff and the wording that you use that's going to make it stick. When we get into those patterns of punitive conversations or punitive negative language, staff sometimes will shut down, especially around hand hygiene. They are so tired of hearing about hand hygiene. And if you ask them the why did they miss a step? Why aren't they performing hand hygiene? If you do that on a one-on-one, sometimes the answers are pretty telling. It's too far to go get the ABHR. The dispenser is always empty. I like soap and water. I don't know why I have to use ABHR. Education, right? Education issue. The other two, not having a dispenser close by, a dispenser that's not filled. Staff are going to, they want to do the right thing, But if we don't give them the tools for success, or we don't help them figure out how to fix the process where things get broken, then we're going to end up with negative outcomes. So that's part of your audit steps, right? Then we monitor the results of audits over time. We talked about those patterns. And then to calculate your compliance rates. So for the compliance rate on auditing, when you do auditing, it's the number of compliant audits completed. And it's, so you calculate your compliance rate. It's the number of compliant audits over the number of audits completed. You divide it. And you're hoping to have, and really when we look at, what a compliance rate should be, it should be 95% or higher for most things. Some things probably need to be 100%, or you're going to have really bad negative outcomes. Others, it could be 90%, depending on the severity of what the outcome could be if it's a missed event. So that's determined by you and your team looking at the particular survey. So that was hand hygiene. The next part of F880 that we're going to talk about.
Yes. Sorry, Jan. There is a question in the chat about, is it okay for employees to carry hand sanitizer in their pockets?
Okay, so that's a great question. And I would share with you, it's not a best practice. And the reason it's not a best practice is you're reaching into your pocket with a dirty hand over and over again, grabbing that alcohol-based hand rub. We have seen facilities cited for having staff with ABHR on their person and doing just that. And if you want to reach out to us, I can find you the 2567, because I believe it was in our region actually, but there was a facility cited for that. Yeah, I know. That is one of those discussion points, right? It's one of those conversation points. I would share with you, if you have staff that are putting linen away, for example, and this is a really picky citation, but a facility was cited for having staff delivering clean linen in and out of resident rooms without performing hand hygiene. And when the surveyor interviewed the staff and put it in the 2567, it was because there was no ABHR located. They didn't have any in their pocket. And then the facility got cited about having staff requirements to keep it in their pocket. That was one of them. What that facility did for their plan of correction is they literally put a ABHR container on their linen cart, on the clean laundry cart. And they also placed them in every resident room. So as you come out of the room, it was right there for staff to use. Any other follow-up questions on that? Because that was a loaded question.
Yeah, I know we are putting together an EVS training with one of our infection prevention partners, Dr. Buffy. And in her video, she addresses that if that is what your facility is requiring, that they need to apply the hand sanitizer, close the lid, and put it back in their pocket, and then apply it to their hands after the sanitizer container is back in their pockets.
Yeah, it's a very picky process. And it's one of those things, right? If you're going to do it, that's fine, but you need to be aware that it's like using soap and water for hand hygiene, right? If your staff are going to use soap and water and that's going to be your preferred method, even though it's not a preferred method under the regs and CDC, your staff better be able to perform it by rote in perfection.
There's some more questions coming in.
Sure.
Would you recommend dispensers in the room or right outside the door?
Both. I know that's crazy. And to think about that as we go into PPE with the usage of PPE, if you only have one, I would say inside the door, like literally right inside the door. And I would do it on the side where the door opens, not where the door swings away, so that it's visual and that you can reach your hand literally around. It's just in a facility where that was how they have it set up. They can reach around the inside of the door without going all the way in the room. You can, it's right there. Like you can get your hand sanitizer. The best though is to have it inside and outside of every single room so that you can develop that foam in, foam out process without having to walk down the hall to get the ABHR as you enter the room. And it eliminates the need then to have it on your isolation carts or your EVP carts if it's outside of every door.
So the next question has, I'm sorry, go ahead.
Nope. What's the next question?
With the new enhanced barrier precautions, does laundry need to wear the PPE?
Laundry should be wearing PPE when they're sorting dirty linen regardless. So unless they're going to be doing some direct patient care that is going to be putting them in contact with the patient under the guidance of EVP, they would not need it in the resident room, right? So under precautions, if I'm going into a room that is under any type of precautions other than enhanced barrier precautions, as somebody delivering laundry or linen, I would need to follow those precautions. Enhanced barrier precautions is very specific to actual physical contact with the resident over a prolonged period in their room. In the laundry room, when we're sorting dirty linens, they should be gowning and wearing some type of goggle to provide, they should have PPE in your linen room or your soil utility room, and you should have a policy in regards to that. Does that answer the question?
I believe so.
Jessica and Amy, you guys can chime in on any of these too.
There are a couple more questions. The next one is, our resident rooms do not have ABHR dispensers in the rooms. What is the best method for hand hygiene in that situation? It is hard to get them to use the sinks in the rooms due to difficulty putting on fresh gloves afterward.
Yeah. So if you cannot do ABHR in the resident room and soap and water is an issue, then you have a real dilemma. And if you're going to have staff put the ABHR in their pocket, you better have very specific education, like Jessica talked about, where your staff understand the complete and can regurgitate that back to somebody upon questioning about how they use ABHR in their pocket, if they're keeping it on their person.
That should probably be a part of your audit too, that there
should absolutely be part of your audit, your competencies. Absolutely. It needs to be all of that. Yep.
All right, there's a question about, we did try ABHR pumps, but a resident thought the pump bottle was face lotion.
Yep. That's why we recommend the dispensers whenever possible. If you're keeping those in the resident room, that's not a best practice because it does leave it open for resident consumption. The pump, where the dispensers, you've got to remember, residents with cognitive issues, residents who have dementia, we learn in dementia that the things that we learn first in life are the things that we lose last. So our first skills that we learn in life are those hardcore memory things that we keep. Think about an ABHR dispenser and when were those introduced into society and into the normal vernacular? Like when I was a kid going to school, I didn't even have a clue what that was, right? Those became norm probably 10 years ago. So for residents, that dispenser, if I have dementia, that dispenser does not look like something that I would recall what it is. A pump bottle, on the other hand, is something that I probably would think is face lotion because pump bottles for, women's makeup, soap have been around for a long time. But those hand dispensers, especially the automatic dispensing, those have been only out, that's new technology. So we can use that to our advantage when it comes to folks with some memory loss, because they're probably not going to recall what that dispenser is, what the purpose of it is.
Also, you could do like a risk assessment in your facility, and if you feel like you have cognitively impaired residents, you can remove them from those rooms or put them higher if you can, depending on the state fire marshal requirements. Camouflage it somehow, put it behind a lock somehow.
Yep, absolutely. There's a lot of things that you can do if you get creative. And I would not do a one size fits all. If you have worries, you absolutely should care plan it and do it individualized. Again, I've heard of cases where residents have tried to consume alcohol-based hand rub, but in these particular situations, and the two that, I've heard of in the last 2 years, it were residents that may have consumed that type of alcohol in their past as a way of either getting, some type of enjoyment from it. So they were alcohol seeking. It wasn't a concern. It wasn't a memory issue for their consumption.
Janet, could I make a comment? Can I make a comment?
Sure. Yeah.
So I recently had a facility, one of my facilities asked me about this. And it is recommended now by the CDC that dispensers are located inside and outside of residents' rooms. But they did provide me with information that facilities should be cautious. The only way they really could be cited is if the facility failed to follow their life safety protocol. So that would be the important thing that you'd want to look into is your life safety codes and make sure that you're following those. And there's actually a great site on the CDC website that I can post into chat if you wanted to go back and look at that.
That'd be excellent. Thank you, Amy. Yes, I know there's like a spacing, like so far, you can't be so far from electrical outlets and the light switches, but they do give you like, don't they give you on that link the actual directions on like where it should be placed, where it shouldn't be placed? So
There's a follow-up question in the chat about enhanced sprayer precautions. They make the bed wearing EBP and they touch clean clothes to put away. So I think.
Yeah. So with enhanced barrier precautions, we have to think about looking at what the regulations tell us around when it's necessary. And it's really related to the actual patient, the actual resident, the actual person and their person. And if I am a housekeeper and I am going in to put clean linen away, the laundry's clean, I'm going into their closet, right? I am not physically touching the person where the MDRO, the wound, catheter, the things that make them at risk and why they're in enhanced barrier precautions. So we have to think about that in regards to how we work with our laundry staff. Now, certainly, you know, you guys as a facility, you know best and you know your processes. If you choose to do something above and beyond what the requirements are, that's in your policy and your process. But the recommendations now are for only staff that have high contact touch with the resident during care in their room or in therapy. Amy, Jess, anything you want to add on that?
Not that I want to add.
Okay.
There's one more, I think,
Okay.
comment in the question and answer. It says, I agree 100% about having ABHR available out and inside of room. However, some facilities don't have that in place. For example, some have a lot of alcoholics that even have attempted to drink from foam dispensers. CDC has the exact procedure on how to do ABHR if carry in pocket. Pull the hand rub container out of the pocket and dispense an adequate amount of gel or foam into one hand. Place the container back into the pocket with the other hand before performing hand rub. Perform hand rub, thoroughly coating all surfaces of both hands. Go directly to resident without touching anything or placing hands in the pocket.
Yeah. Yeah. So that's the process, right? I think that's what you're talking about with Dr. Buffy. So if your staff can do that and you can guarantee that they're doing that correctly 100% of the time, and that's your process, that's excellent. For those facilities that, you know, have the ability to be able to do and utilize ABHR inside and every room, that is the easiest and probably the quickest way to get staff to perform hand hygiene effectively. So I think Dr. Buffy, you said she covers that in one of her videos that we're going to be publishing here soon.
I don't know the exact date, but they will be coming out and we can share the link once those are out.
Awesome. Thank you, everybody. This is great discussion. You know, that's what this is intended to be. It's a discussion. And it's not a one size fits all for all nursing facilities. You know, if you're a nursing facility that handles a lot of folks who are alcohol seeking, then yes, you are going to have a very big concern about the use of ABHR, and your policy probably should be keeping it out of reach of residents. But if you're a facility that is not a high risk, you're not a high risk for that, it goes back to your facility assessment, which we all heard about, right? It's going to be put out on steroids again. We're going to be looking at those facility assessments and knowing the types of residents that you care for and catering your policies and procedures to your resident population and the type of residents that you serve. It's going to be critical. Any other questions before I move on? If not, all right, let's jump into PPE. So under F880, PPE consists of specialized clothing or equipment worn by an employee to protect themselves. It's gown, gloves, face mask, eye protection. The purpose of using PPE is to prevent contact with infectious substances and prohibit the spread of infections. It's needed for a resident in isolation, and it should be listed on the sign outside of the room. And there's the NIOSH PPE information link. Here's the donning sign that I think everybody is very, very familiar with. It's put out by CDC. And then obviously here's the doffing sign. So best recommendation for this is that if you're going to put somebody in isolation, that you use laminated purchases or some type of way of having the sign close by or in or on top of your isolation carts. I've seen them in all three places, just someplace for staff to have as point of reference, and more importantly for residents, families, and people visiting to have as a point of reference to make sure that they're donning and doffing in the correct order. So in F880, it talks about education and compliance. We need to think about what to do if a resident states, so, staff need to understand that it's not a resident right. The resident doesn't have the right to refuse you using PPE. Even though they say it's okay, they don't really need to use it. Residents have said that. Residents will say, oh, I don't want you to wear that. It's sad that I can't imagine being a resident having somebody coming in PPE, but we are here. And so the education and compliance also includes the procedures that require. So staff need to be educated on all of those processes that we talked about with hand hygiene. So passing linen, ice water, picking up meal trays, picking up garbage, cleaning the rooms. That education under F880 is required upon hire and at least annually. And it is recommended that you do more than just RELIAS modules. There needs to be some type of return demonstration and competency as part of your education with staff. And again, we go back to those surveillance audits and observations. By performing those, that's how you really know if staff understand and can apply the concepts and practices. Again, you could do scenario-based conversations. You could do interview conversations. You could have them walk through how they don and doff and when they don and doff and why they do it. Here's a validation, a competency validation example. And this is from down here, Patty linked it to, it's from SPICE, which is the University of North Carolina's infection control. And then here's some resources. There's a link to our resource page on PPE, a link to the DHS, Agency for Healthcare Research and Quality, that actually has a quiz, which is kind of cool to use. There's that SPICE link, and then the CDC link with the isolations. Any questions about PPE? That one's pretty straightforward, right? So let's talk about respiratory protection programs. Let's talk about using those N95s and PAPRs. So healthcare workers are exposed to respiratory hazards, viruses, bacteria, and chemicals. Under F880, the components around respiratory protection is that we need to make sure that staff understand why. They need to be able to understand the signs and the instructions. They need to be able to understand when source control is needed, why we use it, when we perform hand hygiene, and then the spatial separation if we're doing some type of respiratory or isolation. And then the PPE used for respiratory protection and N95s. And do we have another question in the chat, Jess?
No, that's a link to our PPE site on Superior Health.
Awesome, thank you. So N95 respirators, you need to have a policy and procedure to ensure that all staff, new staff, are fitted for an N95 and that they've been fit tested. It needs to be for all staff, including staff who come into work in your building, even if they're coming into work one day. So if we're talking about agency staff in that example, you need to have a process for each employee to be refitted annually or when indicated due to change in like facial composition, if they've lost weight, gained weight, required if they had some type of facial structure change. You need to have a process to identify that in your policy to redo that fit testing. As part of your fit testing, there is a medical screening, a medical evaluation and clearance that needs to be completed prior to the employee being fitted for their N95. And what we recommend for fit testing is that several staff members in the facility be trained to perform the fits. Either quantitative or qualitative tests are used, and that by utilizing a team approach for train the trainer for fit testing, your staff will then be able to maintain ongoing compliance with N95 fit testing. You also need to maintain the records of the fit test for the employee, and you need to meet and maintain those records as part of an OSHA requirement. So this is an OSHA requirement along with part of F880. And when we talk about the records of fit testing for your staff, the N95 fit testing, we need to remember that those fit tests, that medical clearance form specifically, cannot be kept just in an infection control binder. It is considered health information for your staff, and it should be kept with any health records that either your human resources or whoever keeps track of your employees' health records, that should be kept in that same manner. So we have to remember that it is a health record for the employee. Here's an example of how to put on and take off a respirator, and this is from the CDC page, and there's the link to that. It's a good guidance if you're doing fit testing with staff. It's just something good to recall for staff on how to put the respirator on and check their seal, and then again, how to remove the respirator. And then here are all sorts of respiratory protection programs. I believe, Amy, you just, Minnesota is doing a unique program where they're going to be assisting with fit testing. Is that what I read today? I know I'm picking bits and pieces of my emails today. I don't know if Amy heard me, I'm sorry.
Yes, Minnesota is offering a fit testing and train the trainer program through funded dollars through the CDC. The service is only provided through March 10th. So it does, it covers 8 regions of Minnesota. So the whole state is covered, but they have 8 different coordinators for that region. So if you're interested in, and if you are in Minnesota, you can actually complete a questionnaire. You fill it out with your information, and then the coordinator will call you and make that arrangement to come to your facility and to provide you with that service. But you
That's
you would have to sign up before May 10th.
Okay. Well, thank you, Amy, for that. I know for those of you in Minnesota, that's a great resource. I would encourage you to tap into it. Michigan and Wisconsin, unfortunately, we don't have anything similar. But if you need support or resources, here's a resource page on guidance on it. The only thing I would caution facilities to remember, I did mention just in passing about agency staff and utilizing contract staff in your building. They need to be fit tested to your N95s. Just because if I come into your building and I'm working as a CNA and I've been fit tested and I tell you I've been fit tested, I still need to be fit tested in your facility to your N95 unless I can prove to you that I've been fit tested to the type and source of N95 that you're utilizing. So just keep that in mind, that staff working in your building need to have that fit testing requirement. Is there any questions about that or comments, Jess, Amy?
It's just important that fit testing is done annually. So you want to make sure that's, and it's hard to
Yes.
keep track when you have new hired staff that maybe not fall in that time frame where maybe you've done a bulk of your staff, maybe at a skills fair. So you want to make sure you don't miss those staff members either. They don't fall out, they're not an outlier, but it does have to be done annually.
Yeah. And the best practice that I've seen is a monthly fit testing clinic where you're doing current hires, like new hires, and then you're doing current employees with their anniversary date of that month. That seems to be one of the best ways that I've seen a facility track it. So they're doing 2 types of fit testing. They're doing newly hired employees, like in May, I'll do all the new hires, and then I will also do anybody with an anniversary date in May so that we don't miss anybody on their annual fit testing. And by having that team of people who can do that fit testing and perform it does help meet that need for facilities. All right.
Question in the chat.
Sure. What's the question?
If you keep agency off of COVID units, do they have to be fit tested?
Depends on what your policy states, and I would caution you on that. If your policy states that you're only going to have specific employees working with your COVID positive residents or COVID units, what happens when you don't have enough staff? What's the contingency plan for your staff? I guess, again, going back to your facility assessment and looking at your risk assessment, how vulnerable are you to have that happen? And really thinking about that policy, and can you defend that policy? Because that really is what it comes down to. I did work with a facility recently that stated that they are only getting agency staff from like 2 or 3 specific agencies, and they have provided the N95s. They provided the agency with the N95s that they utilize in their building, and they asked the agency to perform the fit testing on the staff to their. I'm like, that was pretty. I thought that was good. If you utilize agency staff and you're utilizing the same agency staff over and over again, I probably would go ahead and fit test them, because the likelihood of them coming in, if we do have a widespread outbreak, you're going to have them working with somebody in a room, with an N95 potentially. All right.
There's
I see
another
more
question in the
comments.
chat.
Sure.
A person thought that fit testing and medical clearance was required every 2 years, and when did that change?
So Amy?
I've never known it to be 2 years, but per CDC guidelines, it is at least annually, and I can put that into the chat as well.
Again, that might be a
sorry.
state OSHA rule, but CDC has other recommendations. Yes.
There's one more comment that fit testing is a part of our onboarding, and any agency go through the same training and competency, which is that is a best practice.
That is a best practice, and that's an excellent practice. Then you don't miss anything, right? They don't fall through the cracks. All right. We're going to move on to transmission-based precautions. I want to give us enough time to talk about enhanced barrier precautions. So under F880, it talks about the different types of precautions, and it talks about staff being aware of the different types of precautions, what they are, when they're used, and how they're applied. So we know that they're used in addition to standard precautions for residents or patients who might be infected or colonized with certain infectious agents, where we might need additional precautions to prevent transmission. There's 4 types of transmission-based precaution that may be used in combination: contact, droplet, airborne, and enhanced barrier precautions. So this is a resource that is on our website that Patty created, and it talks about kind of giving, I like this slide because it gives you examples of the different types of transmission-based precautions, and it kind of breaks down like what's required in each of them. So there's the link to that. I encourage you to go in and grab that link and review this and include it in your education and training. I think it's a really easy to read slide for staff that are being newly trained on precautions. And education, competency, and auditing for transmission-based precautions as for other IPC practices. Staff need to be educated upon hire and at least annually, and your competencies of staff performance of the procedures. So again, this is something that you could do auditing and surveillance on to provide feedback on the understanding, so that you can see if your staff are doing this per guidelines. So a lot of ways to do this. Again, observation, just going up and down your halls, doing those interviews with staff, actually physically having staff, you could do pre and post tests possibly if you're doing some education, but it's good to just bring this out and back and forth. And I'm sure with everybody rolling out enhanced barrier precautions, you have done a ton of education around precautions. Here are some resources on transmission-based precautions. And again, Superior Health has several pages of resources, and we do have a bunch of resources in regards to enhanced barrier precautions. So I'd encourage you to review those and look at those. So in summary, standard precautions, hand hygiene, PPE, respiratory hygiene, proper patient placement, cleaning and disinfection, proper linen handling, safe injection practices, and handling of sharps fall under F880, along with transmission-based precautions and then surveillance. So we're going to talk about surveillance, but before I jump into that, I know we took a lot of time talking about enhanced barrier precautions and hand hygiene questions, and I love that conversation back and forth. It's critical. So we're going to spend a lot of time throughout the 5 weeks on surveillance and auditing. We're going to dive in. So this is a definition about surveillance, and this is directly from the State Operations Manual, Appendix PP, affectionately known as the rules, the regulations. And they define it as an ongoing collection, collation, and analysis of data with timely dissemination of information to those who need to know. The facility needs to develop a system of surveillance designed to identify possible communicable diseases or infections before they can spread to persons in the facility. So we're doing surveillance to make sure that we keep infections at bay and from spreading to others where we could potentially cause harm. So there's two types of surveillance. There's process surveillance, which is the review of processes or practices by staff directly related to resident care. The purpose of this type of surveillance is to identify if our policies and procedures are being followed, if they're effective, and we do that by auditing and observing how staff perform our policies and procedures, and they're conducted concurrently. Outcome surveillance is identifying specific infection events. So it's that infection and pathogens to monitor among the residents and staff. So this is like your line listing. It's how we identify, it's the numbers of people that have certain infections. It's the identifying on a map where those infections are listed. It helps us identify outbreaks, patterns. We look at the results, we look at common factors, common denominators, and it helps us implementing mitigation and corrective steps. And perhaps if we identify patterns or clusters, we're able to mitigate it at a very close level to stop the flow or the spread of that potential infection or outbreak. And it's conducted concurrently and retrospectively. So we do look at this event. So it's ongoing data, and we also look at it for past events. So we look at patterns of things that occurred like the past 30 days. So your line listing is kept up, and you do review that and look at it for continuous patterns. So here's your line listing, your report, and your log. Your line listing can be a software program. It can be standalone, like a software that overlays on top of your EMR. It can be integrated into your electronic medical record. For example, it's part of point-click care, or it can be an Excel spreadsheet or even a paper record. Record resident antibiotic starts, their signs and symptoms of infections, their lab results, and we monitor and update it daily. We go to those IDT, those interdisciplinary stand-up meetings. We look at new antibiotic starts. We look at why those antibiotics were started. We look at their lab results. We look at signs and symptoms, reporting of vital signs, and we review it for clusters, patterns, and consider outbreaks or any other unusual infection findings. And we should have a separate line list for COVID or any outbreak. If we start to notice a pattern of outbreak, you need to start immediately a separate reporting or tracking tool to keep track of an illness log for not only the residents on their outbreak, but also staff. And we should use this at the end of the month with our antibiotic surveillance criteria to calculate our infection rates. So here's two resources, and it looks like, do we have any other questions, Jess, or is that you just popping something in the chat?
There's a question related to enhanced barrier precautions. Do you want to wait till we get into that portion?
Yep, can we wait till we get into that and we'll jump back at that. Okay, so under outbreak investigation and surveillance, the definition is the occurrence of more cases of a communicable disease than expected in a given area or among a specific group of people over a particular period of time. For example, norovirus, influenza, scabies, viral illnesses, MDROs. Those are things that we don't expect, right? Those are the abnormals. So the purpose of the outbreak investigation is to stop the transmission of the pathogen and prevent additional infections. Early recognition is important. Implementation of steps to prevent the spread are those key items: isolation, testing, resident monitoring, staff education, and then compliance monitoring, and then the other steps that go with that. Notifications of your health department, residents and families. And then in any outbreak, it's critical, and I know it's really crazy busy. When you're in the middle of an outbreak, we don't think about all the stuff that we do, but we need to record it. Designate somebody to keep track of what it is that you've done and when you've done it. It can be as simple as a yellow pad of paper on your desk that doesn't move. Write down, notified the health department today, emailed this person, social work made phone calls to families to notify them the outbreak. XYZ provided education to our staff. Track that. That is your proof that you address the outbreak. And so when you do your after action report, you have all that information and you can present it in a format of a timeline and a written scenario synopsis to present at QA. And you also can then use it to do that after action to talk about what worked well, what didn't work, and what were your lessons learned from moving forward. So what is the role of the infection preventionist in surveillance? You need to know what's going on in your building, obviously. So you're kind of like the gatekeeper of all things infections, right? You go to your morning meeting, you need to know who's coming in, who has illness, there's a change in condition, is there anything infection related? You need to make sure that you're auditing, monitoring, and observing what's going on in your building, and research, be out and about, know your staff, know what, kind of have a feel for where you're, what's going on day to day, what the vibe is out there on the floor. You need to maintain your line listing for both residents and staff illnesses. And there are many things that you need to keep track of: residents, potential admissions, staff, processes and procedure updates, processes and procedures in other departments, what's going on out in your community and your hospitals, what's going on out in the, from an infection standpoint. Is something new coming into the community? Are you getting information? It's not as overwhelming as you think, but making sure that you have a system and process in place to keep yourself organized and getting a routine is probably the most critical piece. And there's a lot of ways to do that. And I think number one thing that I would recommend to you if you're a new IP is talk to somebody in your organization that is a seasoned, well-oiled machine infection control program. Who has that program and how do they make it function? Learning from them about how their systems and how they keep themselves organized will help you figure out what system and organization skills or organizational tools that you want to implement in your program. So here's an example of the IP's daily routine. I'm going to make sure that you check communications report. You want to round and check in with your charge nurses. You want to round and observe, infection prevention practices, do those audits, provide one-on-one if needed, check isolation carts, attend daily meetings, review your line listings, review potential admissions, and then any updated guidance and take to the team meeting to discuss. You are your subject matter expert of infection control in your facility. And here's some surveillance resources. Module 4, which you probably, if you took the CDC train course, just good to go back and look at that. APIC had this article about recommended practices for surveillance, and it was an excellent article. And then we'll talk about month-end analysis next week because we're running close to time. And I want to get back to enhanced barrier precautions. So Jessica, what was the question?
So the question is, for the 802, would enhanced barrier precautions trigger checking transmission-based precautions for residents? We are going back and forth due to wording. Some thought it was stated somewhere on the CMS that EBP are not to be treated as transmission-based precautions.
So that is a gray space, and I think that's a great question for us to put out to the survey agencies. I had this question from another facility, and technically there is not direction, right? We have, I did not see it. Did anybody see that on the call? Did anybody read that in the regulations that it is not to be treated? I believe it's not to be treated like transmission-based precautions. It's different and unique. And if the wording isn't on the 802, I don't want to give you bad advice on that, but again, I would check with your state licensing officer because I bet they're as confused as we all are yet, because there's not been a lot of regulatory, implications on this yet. And I don't think until things go through multiple surveys and we start to see trends, are we going to start to see things kind of weed themselves out, unfortunately. I wish I had a better answer because that is a great question.
The next question pertains to surveillance. Do we have the actual URL to the Minnesota and leading edge tools for line listing?
I can get them. So if you want to send us, do you have the name of that individual? Because I can't see the chat, so I'm sorry.
It was an anonymous.
Okay, so I'm going to jump.
Attendee.
I'm going to jump through the bottom here, and so that you have our emails. This was a big, there's Patty's email. So if you want to throw our emails in the chat, Jessica, they can email us directly with that question and we can get those URLs to them. Any other questions that anybody has? It's a big topic. I know this was going to be, this is going to have a lot of questions around the AVHR and enhanced barrier precautions, particularly. Anything else coming through in the chat? If not, we are at time, and I just want to give you guys a shout out. Deep breath, deep cleansing breath. You guys, nursing homes this week have just been, the last 3 weeks have just been barraged with information and new changes. So patience and reassurance. I wish I could give you all that reassurance that things are going to be okay. So thank you for your time. We will pick up where we left off that last bit of slides next week. And I look forward to seeing you next week. And you will definitely be speaking next week. It will not be me. Patty will be joining us next week. So Patty, Jessica, Amy, anything that you want to add?
No, thank you for your participation and attendance today. It's been great.
Yes, it has been. Thank you so much. I appreciate
Thank
all the questions. Thank you.